Hello, I'm Sven Eriksson, a postdoc research fellow at the Esophageal Institute at Allegheny Health Network, Pittsburgh, here to discuss our recent paper in the Journal of the American College of Surgeons on the impact of objective colonic and whole gut motility data as measured by Wireless Motility Capsule on the outcomes of anti-reflux surgery. Optimization of anti-reflux surgery outcome is chiefly achieved through patient selection, utilizing foregut factors associated with outcome, such as typical primary GERD symptom, abnormal esophageal acid exposure, and symptomatic response to PPIs. Previous studies have suggested a pathophysiologic link between the foregut and the hindgut, and have found a higher rate of dissatisfaction with anti-reflux surgery outcome in patients with chronic constipation. However, a relationship between colonic dysmotility and anti-reflux surgery outcome has never been established with objective data. Therefore, we designed the study to assess the impact of objective regional and whole gut motility data on anti-reflux surgery outcomes. 48 patients underwent a complete foregut evaluation, including manometry, EGD, wireless pH monitoring, esophagram, and wireless motility capsule testing prior to anti-reflux surgery. Wireless motility capsule technology consists of an ingestible capsule with temperature, pressure, and pH sensors that can measure regional and whole gut transit times, motility, and pH, which can then be used to diagnose GI motility disorders such as gastroparesis and constipation. Postoperative symptomatic assessment and objective foregut evaluation occurred at 1 year or later after surgery, with favorable outcome defined as complete resolution of the primary GERD symptoms and freedom from PPIs. Looking at the relationship between wireless motility capsule GI physiology data and foregut testing data, we found a direct relationship between colonic transit time and hiatal hernia size, with significantly slower colonic transit in patients with a greater than 3 centimeter hiatal hernia. We also found an inverse relationship between colonic pH and preoperative distal esophageal acid exposure as measured by Demeester score, with the longest reflux episode component of Demeester score showing the strongest relationship. Looking at surgical outcome and GI physiology data, we found that at a mean of 16.8 months, 87.5% of patients achieved favorable outcome, with symptomatic relief in 89.6%, freedom from PPI in 93.7%, and pH normalization in 75%. Analyzing the transit times for different regions of the gut, we found that patients with suboptimal outcomes had significantly slower colonic transit times. Looking at the pH data, a higher colonic pH was also associated with unfavorable outcome. Previous studies have suggested a correlation between lower abdominal symptoms and anti-reflux surgery outcomes. However, this is the first study to demonstrate an association between objective colonic dysmotility and suboptimal anti-reflux surgery outcomes. Wireless motility capsule testing has a role in assessing objective GI pathophysiology and provides valuable information for preoperative discussions of risk stratification and expectation management for patients seeking anti-reflux surgery. Thank you for watching.